Hi, everyone. Welcome back to the Miri channel. My name is Miri. I'm a licensed occupational therapist. And in today's video, I'll be discussing the evaluation process and intervention strategies for patients who have had a stroke. And since I'm an occupational therapist, this video will focus on occupational therapy assessment and intervention, where the focus is on improving function in areas of our daily occupation. Now, there's going to be a ton of content and information covered today, so I'm going to break it up. And today's video will only cover evaluation and intervention for motor impairments as well as upper extremity impairment. Now, this video is part 2 of a series I'm doing on stroke. So if you haven't watched part 1, where I provide an overview of stroke along with some of the most commonly seen functional impairment, be sure to check that one out first. And if you did watch the first video, you know now that this series was inspired by my very dear friend, Peter, who passed away during the pandemic from a hemorrhagic stroke. And in remembering him and to honor him in the best way that I know how, I wanted to share as much as I know about stroke and raise awareness and increase knowledge in a way that directly translates to improved care and compassion for patients with stroke. So this video series is a little different than my other ones in the sense that it's more dense and it's packed with information, and it's really intended to serve as a thorough introduction for you to really learn the condition and effective ways to evaluate and treat. And I say introduction because as much information as these videos contain, they're still really just an intro and things you need to know as an entry-level therapist. So for those of you who want to go into this setting, I'll list some great resources that you can utilize that I personally enjoyed in the video description, as well as in the study guide that'll be available on my website at otmiri.com. All right, so let's get started, and we're going to begin with the evaluation portion first. But before we dive into evaluation of specific impairments, I want to kind of walk us through a theoretical evaluation framework that's commonly used for people who've had a stroke, and it's the occupational therapy task-oriented approach. Now, this is going to take us several minutes. So if you're already familiar with this approach and how it plays out during the evaluation process, just go ahead and fast forward. But if you're not, please follow along because it's an important approach to consider for neurological conditions like stroke. And I'll be referring to it quite a bit in this video. And I just want to remind you, especially if you're feeling really pressed for time and want to just find a shortcut like all of us do sometimes, that instead of trying to take little snippets here and there and memorize what you think you might need to know, it's better to learn the concept in its entirety, especially when it comes to learning about stroke. I mean, how many of you guys that are preparing for the board exam have experienced this, where you have read the same sentence over and over again from a study guide, and while you understand each word of what the sentence is saying, you don't quite understand what the whole thing means clinically or how it applies, so you end up getting all the practice questions wrong. And that's because these study guides are meant to be a review. And if you haven't learned it or don't have a conceptual understanding of it, you won't be able to truly put it together and understand it. And that doesn't mean you have to learn every minute detail. You can still keep it broad. But I think learning this in a cohesive way with a complete picture will actually allow you to put the pieces together. So it may take greater time investment now, but I think it'll save you time in the long run. So stay with me and let's get through this together. So what is the occupational therapy task-oriented approach? Well, in short, it's a top-down, client-centered, and occupation-focused approach that looks at the interrelatedness of the person and the task and the environmental factors on our motor performance. And this approach is informed by multiple theoretical perspectives, so it holds numerous assumptions, but one of the very important assumptions of this approach is that our performance, our occupational performance, emerges from the interaction of the person and the environment, and that functional tasks, so things that are goal-oriented, purposeful activities that have some functional purpose, help organize our behavior, especially when those tasks relate to our life roles. So it's really a top-down approach that places the focus on the roles and activities that make up those roles. So what does that mean in the context of an occupational therapy evaluation? Well, there are 5 steps as described by occupational therapist Virgil Matthewitz, and it's such a great framework to know and keep in your mental toolbox for whenever you need to evaluate a patient who's had a stroke. So to illustrate these 5 steps, let's use a patient named Darcy as an example. It's not a real patient. Have no idea why I just came up with that name, but let's say that Darcy is our patient and you are the evaluating therapist. The first step of the evaluation using this approach would be role identification. So instead of starting at the impairment level and focusing on the dysfunction, we are focusing on the role and current ability in those roles, because the goal is to ultimately resume those roles. So depending on Darcy's cognitive status, you can use something like the role checklist, which is a self-report measure to assess roles that are significant to her, and we can gauge her level of motivation. Or there's also the occupational performance history interview, OPHI, too, which is very comprehensive, and it takes about 50 minutes to administer, so not always practical or realistic to administer, especially if you're in the ICU setting. But those are some of the assessments you could use to identify the roles that are important. Then comes step 2 of the evaluation, which is observation of occupational performance through their ADLs or IADLs. And that makes sense, right? I mean, how can we determine our patient's impairment and how they will affect their functioning in the real world if we don't observe them doing or performing the actual task? And this observation of a functional task can take place through just casual observation of any ADL that they may be doing when you walk into the room. So by watching how they're rolling in bed, so bed mobility, how they're sitting or not sitting, or how they are bringing themselves up from sitting. Are they using their arms or is it dangling? I mean, you can get a lot of useful information just from observation and movement analysis. You can also gather information more formally by assessing them through various assessment tools that are available that measure ADLs and IADLs. And those include, and you guys have heard this before, the Barthel Index. More specifically, there's the stroke impact scale. There's also the assessment of motor and process skills, also known as AMPS, as well as the Attendeer OT ADL neurobehavioral evaluation. Oh, that's a mouthful, but it's also known to referred as A1, so you can say A1, both of which are really great assessments because they're very client-centered and will allow you to assess ADLs in the context of an occupational performance. There was another one. The Canadian Occupational Performance Measure, COPM. I really like this one, which measures the patient's perception of their own performance. So what they think of their own performance and their satisfaction with it over time. So there are some really great assessments out there to observe their ADLs, but ultimately, whether you choose to do an informal observation or to use a standardized assessment or both will really depend on the patient's current level of ability, as well as the setting that you're in. Which brings us to step 3, which naturally follows the progression from step 2, and that is task selection and analysis. You guys remember learning about activity analysis in school, right? If you haven't, don't sleep through this portion of lecture in school, because you're going to realize sooner or later that this is a very valuable skill that's unique to the work that OT clinicians do, and it's going to follow you all the time. So here in this step, you're observing the patient performing functional tasks that have relevance to the desired role that we identified earlier. And you're doing a thorough task analysis. So looking at the patient's performance skills and patterns that are specifically affecting or limiting their performance. And this is where we begin to selectively identify those unique client factors that need to be addressed. And that can be their cognition or visual impairment. Is it the upper extremity impairment? And this, you guys, will ultimately save us time by pruning out things that we don't need to look at and helping us zero in on factors that truly have functional implication and allowing us to specifically work on areas that are limiting their performance. So in the case with Darcy, let's say you selected meal prep as a task and you're observing her. And while you are taking notes, you notice that she is constantly dropping things. She has poor sitting posture and says that she's too tired to complete the task, and she never attempts to use her affected right upper extremity. Well, based on these observations and task analysis that you do, you decide that you need more information. And this is where it brings us to step 4 of evaluation, which is to administer specific assessments based on clients' unique factors and performance skills and performance patterns that were just observed. So in this step, because you noticed several sensory motor factors like decreased strength and sensory issues, and you noticed overall impairment of the upper extremity with Darcy, you might do an assessment of sensory function. You might assess for pain, look at range of motion using goniometry. We might also assess strength through manual muscle grades. And if you have more time, depending on the setting, you might decide to administer other assessments that are specific to the upper extremity, like the Wolf Motor Function Test. All right. And so that brings us to the last step of the evaluation, and that's looking at the environment. So here we are assessing the activity demands and the context and how that might impact or influence our patient's performance. So this is where the environment piece comes in, where earlier I mentioned that the task-oriented approach looks at the interaction of the person and the environment and the impact it has on our performance, right? So we would observe our patients performing their task in various different contexts, which would give us information on the influence of the environment on performance. And we're looking to see, is the environment helping or is it limiting their performance, so that we can adapt the environment if necessary. So that's the occupational therapy task-oriented approach in a nutshell. And obviously, you guys, all of these steps that I just laid out may not always play out in this exact order or in its entirety, especially if you're in the acute care setting. But this framework is really helpful to know and keep in mind, okay? So now that we've gotten that out of the way, I want to dive right into the meat of what this video is about: evaluation and treatment for motor impairment. So in my previous video, we talked about the importance of trunk control and how postural adjustments that serve as balance mechanisms are impaired after stroke. And to be able to do anything, we need trunk control. It's a prerequisite for controlling our everyday movements. And from a safety standpoint, working on postural control is especially important in the early rehab phase, because without balance and stability, we risk a fall. So during evaluation, when we are observing our patients, it's important to assess our patient's alignment, trunk control, and balance. And we can do that by simply observing them while they're seated. So we are looking to see if the patient can assume a static sitting posture. And we're looking at the alignment, any asymmetries you might notice, and their ability to perceive midline. We might also want to look for specific deficits in trunk control. And one of the most effective ways to assess postural control and adaptation is through observation of a functional task. So depending on their level, we can initially have our patients do something in sitting that doesn't require a lot of trunk movement or weight shifting, like wiping their face with a towel. Then we can progress to activities that require great trunk, or greater trunk response, like reaching for something beyond arm's length. And we can notice and take note, how stable is our patient while reaching? Are they able to pick up an object that they dropped without losing balance? So observing these sort of control reaching activities during functional tasks will give us a lot of information and insight into how well they are able to maintain trunk control through different positions and movements while they're seated. All right, so we've done the evaluation now, and we're ready to start the session. What do you think might be one of the first things we want to do with our patients? Well, one of the most important things we can do is to get them in a good upright posture with proper alignment and good base of support. This is so important before you get them to do anything, because without that upright postural stability, patients will have a harder time engaging their arms for any of ADLs. So let's go over what that looks like. Can we do this together? Let's actually get a feel for what this posture feels like. So first, we're gonna get both of our feet on the floor with them weight bearing on the floor. Now, move your pelvis in neutral to slight anterior pelvic tilt. And we're going to make sure that there's equal weight bearing on both ischial tuberosity. And these are your sit bones at the bottom of the pelvis. And it's colloquially known as the sit bones because you literally sit on them. So get equal weight bearing on those sit bones. Now we want our spine erect with our shoulders symmetric, and get our head over our shoulders and our shoulders over our hips. Okay. Wow. I feel better. Do you guys feel better? I just realized that I've been sitting in a really bad posture this whole time. Well, this, you guys, is what we call a good starting seated position that's ready for action, meaning this is the position that best prepares our patient to engage in a functional task. So if you walk in and see a patient sitting in a wheelchair in a slump position and their hips are extended, what are we going to do? What's the priority here? We're going to reposition them, get them in an upright posture with their hips flexed and get their arms supported. And remember, patients with hemiparesis may need frequent repositioning. So maintaining this upright posture is not something we can just do once and sort of forget about. All right. So we got our patient in a good starting position and alignment. What next? What else can we do? Well, if we've done a good and thorough evaluation, we'll have a pretty good idea of where to start with our patient to engage them in a functional task that provides just the right challenge. So let's say that your evaluation revealed that your patient with right hemiparesis has poor postural stability and has difficulty stabilizing her body. What kind of treatment can you do with her? Well, the treatment might begin by simply sitting at the edge of the bed to work on supported sitting while working on her ability to keep her trunk stable. So early in rehab, we might have to keep it just simple and safe and graded appropriately to their level. And while keeping the trunk stable, we can start to involve the limbs and get them moving for functional tasks like putting lotion on the face. Then as the patient progresses along, we can increase the challenge by having our patients engage in functional activities that actually gets their trunk to respond. So we want to activate trunk response. And one of the ways we can do that is by having them engage in reaching activities. So this is a great way to work on postural stability. And these reaching activities may be similar in nature to what we were doing to assess them during evaluation, only this time we're using the information that we gather through assessment to provide a highly individualized treatment plan that specifically addresses our patient's goal and grading it to their current level of ability. So for example, we might change the complexity of the reaching task by changing the location of the objects. So in both the distance as well as the direction of the reach. So you can control how far they have to reach and the direction you want them to reach. And in addition to working on postural stability, this sort of reaching activities also provide a way to practice dynamic weight shifting, because reaching beyond arm's length not only requires postural change, but it also requires weight shifting, which promotes weight bearing through the pelvis. All right. But remember, we gotta maintain that proper neutral alignment we discussed earlier when we are doing these activities and going through them, because the distance and quality of our reach is much better when we're in proper alignment. And you can try this with me. Sit slumped in your chair and try to raise your arm. Okay. I mean, this is as far. Now, it doesn't go up as high as if you were to sit straight up and raise your arm. I mean, I don't even have to move my arm. Like, just by virtue of sitting up, my arm naturally goes up straighter and higher. And you can demonstrate what we just did here with your patient too, because it might be helpful for the patient to feel the difference between a posture that's aligned versus one that's slumped and misaligned. Okay. Now, one thing to keep in mind as we're doing these activities with our patients is we have to be sure to continue to do movement analysis and assess their skills and performance with task demands to make sure that the task matches or corresponds to their level of motor control, meaning don't give them a task that's too hard for their level. And that's because many of the inefficient movement patterns that we see after stroke is partly due to patients attempting to do something that's beyond their level of motor control. So as therapists, we want to continually assess and try to minimize those inefficient movement patterns by choosing tasks that are appropriate to the patient's level of available motor control. All right. So we talked about proper alignment, weight shifting, weight bearing, and reaching activities through functional tasks. What else can we work on? Well, we know that patients have difficulty perceiving and maintaining midline after a stroke, which leads them to sitting postures that are misaligned, right? So another thing we can work on is maintaining the trunk in midline. So you might give a physical cue or just verbally ask the patient to sit up nice and tall. You can use a visual feedback like a mirror. But aside from giving these cues, another way you can work with a patient to help them keep their trunk in midline is actually to work on trunk strengthening and range of motion, because studies have shown that improving our trunk range of motion and strength can help. So we can do activities and engage them in tasks that require the trunk to work against gravity to help improve their strength. All right. Okay. Oh, all right. So all these things that we just discussed are great strategies to improve alignment, strength, postural adaptation, and trunk control. But sometimes remediation may not be possible because of the severity of the impairment or cognitive deficits, or because there simply isn't enough time for therapy. And if trunk control is not at a sufficient level, this will really put the patient at risk for injury. So in these cases, a more compensatory approach might be indicated. And here's where we pull out our assistive equipment or make environmental adaptations. So we can adapt the wheelchair, for example, to provide good head and trunk stability by adding lateral supports, lumbar rolls. We can put in chest straps or pillows and cushion for propping, all of which can help compensate for poor trunk control. Other examples of using compensatory strategies would be providing adaptive devices like reachers or long handle equipment, which will not only help our patients increase independence, but that'll help them compensate for poor trunk control, because it will actually decrease the amount of trunk displacement, which will ultimately help prevent falls and injury. You can also adapt the environment by changing things around, like storing things within patient's arm reach. And I actually did this myself when I was like 9 months pregnant, and I fell one time, and that was a scary event. So I employed what OTs do. I employed my OT strategy to prevent another fall, and I did that by rearranging my kitchen, my bathroom, everything. I ended up storing most of my dishes on the counter where it was easy for me to grab and store. I brought everything out of the medicine cabinet and from under the sink, and I organized them all on the counter at the sink level so I wouldn't have to reach over or under. And my house still looks like that after 3 years. I am ready to age in place here. But these are some of the things that you can do as well. So depending on the patient's needs, our treatment strategy can focus on remediation, compensation, or both, and understanding when to use what approach and its implication, functional outcome, and recovery is very, very important. All right. Okay, so everything we just covered was related to how we work with a patient who has impairment in trunk and postural control while seated. But how about when the patient is standing and moving about? Well, we know that with standing, there will be functional limitations and activities that require lower extremities. So we're assessing our patients for standing activities. It's important to assess their postural alignment, symmetry, and base of support, because these factors affect our balance. So we want to look at how their body parts are positioned over the base of support to provide that upright postural stability. Now, up to this point, we've been talking about how important it is to incorporate treatment strategies in the context of functional tasks, right? And that's especially true and important when we are assessing our patients in standing, because as our patients begin to move and engage in an activity, the alignment and symmetry changes too. In fact, just by standing up, the configuration of our base of support changes in many ways. Okay, so movement creates conditions that will elicit postural reaction and challenge postural stability. And this will allow us to observe the patient's balance as well as their automatic postural reactions. And speaking of postural reactions, do you guys remember those three important postural reactions and balance strategies we discussed in part 1? I hope you didn't forget. It was the ankle strategy, the hip strategy, and the stepping strategy. And those are often impaired after a stroke, right? So we want to be looking at that too and observe to see if these automatic postural responses are getting activated while they're standing, shifting weight, reaching, etc. All right, so while the patient is standing on a firm surface, take a look and notice, is there swaying and oscillation around the ankles? What happens when they begin shifting weight or reaching? Your patient might be able to maintain stability while standing, but can they remain stable while moving about, while engaging upper extremities? And what happens when they move to an uneven surface or to a narrower base of support? So these are some of the questions that you can ask. Are they able to regain their balance when their balance is thrown off? And does stepping strategy kick in to compensate? And if it does, is it delayed? So we are looking for patterns of dysfunction and observing to see when they lose balance, as well as determine situations when they don't lose balance, because that's telling too. There's so much information we can get through just observation alone. Having said that, there are also formal assessments that you can use to assess balance. And while they may not be in the context of functional task performance, they can still give us useful information. So those include the Berg Balance Scale, which might be one of the most commonly used balance assessment. There's also the Timed Up and Go, as well as the functional reach test, which is a quick and easy way to measure the reach length and assess our patient's stability, as well as their maximum distance that they can reach while standing in like a fixed position. And while we're on the topic of balance, I want to mention one more thing. And I learned this in my business class, and it's something that always stuck with me because I always had this fear as a student and new grad that my patient would have this really bad fall under my watch. And it is that if at any point you're with your patient, whether you're evaluating them during supported sitting or doing transfers to and from the bed to chair or commode, wherever it may be, if they begin to slip from your grasp and you can feel them falling, don't try to reverse the course. Go down with them. And that doesn't sound right or intuitive, right? But we must not try to lift them back up or to move them quickly back to the bed or to the commode or to the wheelchair, because you'll not only increase the chance of a greater fall impact for the patient, but you might get hurt yourself. And also, don't just stand there holding them up by the armpits with all your might while you scream and wait for help, because help might not come in time. So if you feel your patient slipping away, ease them down gently to the floor with as little impact as possible. Then call for help. All right. So we covered evaluation and we're ready to work with patients in standing. What are some strategies we can use to help improve our patients' ability to engage in tasks while standing? Well, just like in sitting, one of the first things we need to do is to get the patient in a good starting position that would provide stability with good alignment and base of support. So let's go over what that proper alignment and optimal starting position looks like for standing. You guys want to do it together? Break time. Stand up. I'm going to stay seated so you guys can see me. I'll just wiggle in my chair and get some break. But I want you guys to all stand up and get a feel for what this feels like, okay? So first, let's get our head in midline. Our shoulders should be centered and aligned over our pelvis with the trunk aligned and symmetrical. Moving down lower into our body, check your knees and keep them comfortable and slightly flexed. And your feet about a hip distance apart with equal weight bearing across both legs through your feet. And you should feel your pelvis neutral and centered over the base of support that's created by your feet. And how does that feel? Do you feel stable? Does that feel comfortable? This is the position that we want to get our patients in. And once this base of support has been established, we can see how the patient stands and remains standing. And getting the symmetric base of support and alignment is a prerequisite before starting any standing activity. All right, so once we get our patients in good standing alignment and stability, what are some things we can work on for postural stability? Well, initially for support, we can have them simply stand in front of a stable and sturdy surface like this one or like a kitchen counter to provide some security and work on weight bearing, staying close to the patient on their affected side. And using the countertop or table to provide additional support is a great example of using the environment to grade the task, which is an important thing to keep in mind while we go through treatment. We must always consider the environment and ways it can limit or enhance our patient's engagement and performance. And in this case, the kitchen countertop provides support and can help decrease our patient's fear of falling while improving their balance skills, okay? Now, as the patient gets comfortable and feels more steady and standing through weight bearing, we can incorporate functional activities that include dynamic reaching activities, like reaching for a cup on the counter. And you can grade these activities based on where you place your objects. So you can determine the distance that you want your patients to reach. So how far do you want them to reach, as well as the direction that you want them to go. So if you want the patient to practice weight shifting to their weaker side, you place the cup on that weaker side. And if you want to challenge your postural control and elicit postural change, you can put that glass further out so they will be forced to reach beyond arm's length, which will elicit postural response at the trunk. So strategic placement of the object as well as our patient's positioning and the environment they're working in, such as having a sturdy table, can all be manipulated to grade the difficulty of the task. All right, so we talked about proper alignment, weight bearing, weight shifting, and doing functional reaching activities and standing. Now, do you know what else the patient can be working on while they're engaged in these tasks? Balance and postural reactions. These keep coming back again and again, right? So let's go through these 3 automatic postural reactions and how they can be incorporated during treatment to improve balance and stability. And the first one is ankle strategy. And if the patient has been working and standing for all of these functional tasks that we just mentioned, they've already been working on ankle strategy, because simply standing and weight bearing while maintaining your center of mass over base of support will require strength and range of motion at the ankles. And that requires ankle strategy. How about when the patient is doing functional reaching activities, like going up on their toes to and lifting up their heel up from the ground to reach something higher up, right? And coming back down. Think about the movement and strength required in the ankles and the plantar flexors when you have to lift that heel up off the ground to reach up higher. So through these dynamic reaching activities and by adjusting the height and the distance of the reach, we are working on ankle strategy. Now, remember, we want to work on these strategies in an environment that mimic reality as much as possible. And this means that we are creating an environment that includes the challenges our patients would encounter in their everyday life while performing a specific task. So instead of having them just reach up and down meaninglessly or sway back and forth to work on their ankle strategy, we are incorporating this movement into a functional task. So if the goal is for your patient to be able to prepare meals for their child, you'd have them practice in the kitchen and have them reach up and over to the top pantry to grab a box of cereal. If our patient's goal is getting back to gardening, you might work on these strategies in her backyard. You might even have her, stand there and water her garden with a hose. Point being, we want them to build their skills in the natural context that mimic the reality that they'll be living in, that they'll be returning to. All right. So now, in addition to ankle strategy, do you guys remember the other automatic postural strategy? The one that gets kicked in, the one that kicks in when ankle strategy isn't enough? That was the hip strategy, right? This is when the perturbation is too much for the ankles to be able to handle. So our hips play an important role in restoring balance. So let's talk about some strategies to work on that too. So for one, we can do this by having our patients engage in activities that require large weight shifts on narrow bases of support. So in other words, using surfaces that are smaller than our feet, like a balance beam. This will activate the muscles that are around our hips and elicit hip strategy, okay? So we can have them stand on a firm, narrow surface. We can have them walk on it, play toss and catch on it. Do games or activities. These sort of activities will help our patients learn to maintain and restore balance, all right? And here is a video of my son working on balance on a narrow mattress board. This is what happens when you have an occupational therapist who is also a mom. Anyway, I put this in here because I want you to visualize this home and my son playing on my house to remind yourself of another important principle of the task-oriented approach that we want to apply in our treatment. And that is to provide opportunities for practice outside therapy time. And that's because we are limited in our time. The amount of time we have with our patient is limited. So we want to encourage them to continue therapy on their own time, okay? All right, so the last one, let's move on to the stepping strategy, which kicks in when neither our ankles or hips are enough to help us regain balance. And this, if you remember, is the one that gets elicited when we're forced to widen or broaden the base of support to regain balance, like when we trip unexpectedly, or when we're on a bus or a train that comes to a sudden halt or stop and we take a step to broaden our base of support, right? So to improve stepping strategies, we can engage our patients in activities that force them to shift weight outside their base of support so they can practice widening their base of support. Okay, so that's all that I'm going to talk about today for improving postural stability and balance. And I want to switch gears now and talk about evaluation and treatment for upper extremity impairments. And the process for evaluation of upper extremity is very similar to everything we talked about up to this point, meaning we want to keep the focus of our evaluation in the context of functional performance. And in the case with the upper extremity, we want to observe to see how they're integrating their upper extremity when they are performing functional tasks, as well as measure their ability to use the affected extremity during performance of these tasks. We are also looking at their range of motion, muscle tone, sensory function, motor control, as well as their strength and endurance. So depending on your patient's unique factors, you might decide to administer other assessments that are specific to upper extremity, such as the Wolf Motor Function Test. There's the arm motor ability test, as well as the functional test for the hemiplegic upper extremity, right? Now, once we've done the evaluation, the treatment would focus on bringing awareness to the affected side and getting the patient to incorporate the affected upper extremity into functional tasks as much as possible in as many contexts as possible. So in this next portion of the video, I'm going to provide several strategies we can use to encourage the use of upper extremity during functional performance. First one we're going to talk about is weight bearing. Now, weight bearing can begin almost at any stage of rehab, even during the acute phase when the patient is in bed. And we can do that through positioning, which is especially important to start as soon as possible for patients who have little activity in the upper arm. So one of the things that you can do to get your patient is to get them in side lying on the involved or the affected side with the elbow extended and the scapula in protraction. But be sure that the scapula is forward in protraction so that the patient isn't lying on the head of the humerus, because that could cause some pain and impingement. Now, if you're like me and you get protraction versus retraction confused, remember that protraction has the word pro in it. And if you think about pros, people who are really good at what they do, pros are people that just keep on moving forward, while in scapular protraction, the shoulder is moving forward. So just remember that we want to be keeping our patients moving forward, literally and figuratively, with scapular protraction. Okay. Now, aside from positioning, another way you can get patients to do weight bearing is just by having your patient sitting in front of a table while weight bearing on both forearms. This might be helpful, especially early in the acute phase when there's little postural control or stability, because this will allow them to use their upper extremity as a point of proximal stability. Okay. Weight bearing can also serve as postural support, and it can be especially helpful during transition from one position to another, like getting up from sitting, getting up to sitting from lying, or just using your arms to push up to stand. Okay, so very good for when you are transitioning from one place to another. And as the patient progresses along, you can incorporate even more weight bearing into functional activities. So if your patient is a former artist, you can have the patient use the weight of his arms to hold the paper down, a sheet of paper down with one hand while using the other hand to paint. If he needs to take a break and go to the bathroom, you can work on using the affected upper extremity as a stabilizer on a grab bar while using the other hand to get toilet paper. So again, tying the activity to the goal or the role that the patient wants to resume. Okay, so that was weight bearing. What's another strategy to get that upper extremity moving? Well, we can increase the challenge by having the patient move things across the firm surface. So this could include things like wiping the counter, ironing a shirt, waxing the car. So this is a step up from simply using the arm and weight bearing as postural support, in that now we're moving the arm, right? Versus just having them static and weight bearing. But it's a step down from having to move your arm in space, since you still have contact with the support surface to give you that extra stability. All right, so I want to demonstrate this activity because I think it's a lot helpful if you can visualize it and see the movements in action. So here I have my weaker hand over the towel, which is really nice to have something under like this. It encourages the hand to open up. It's relaxed and resting, nice and easy. And I'll bring my stronger hand over the weaker hand just to give it extra support and help guide it as I move the towel across the table. And I want you to just watch and observe and notice and tell me, where is the movement occurring? Well, you guys can't really tell me. I always forget that you're not in the room with me. It's so funny. When I make these videos, I always feel like we're all sitting together in the same room, having fun and having a conversation. And then I realized that that's not the case. But you guys can still tell me in the comments. Did you guys notice that the movement is occurring at the trunk level? My trunk is moving in flexion. Okay? And another thing, if you'll notice, is that I have my chair placed really far away from the table, and I did that intentionally because I wanted to get a lot of range of motion. I wanted to move and get that muscles on length and stretch, and one of the ways you could do that is to have the patient sit further away from the table. So I want you guys to notice something else here. I'm gonna stop right here to stretch and get that muscle on length. And do you see that scapular protraction? Good stuff. Right? So this activity is getting our body moving in the direction and in the positions that we want. So we have scapular protraction, we have elbow extension, humeral flexion, okay, and trunk flexion. Great way to get our patients to do self range of motion. Do you see that? Again, scapular protraction, elbow extension, humeral flexion, trunk is moving, putting those muscles on length and getting that range of motion in simply by wiping the table. So this kind of activity prepares them to be able to reach for objects in space, which takes greater control and strength, like reaching in the refrigerator to grab an apple or reaching under the sink to grab toiletry. Okay, and that brings me to another strategy we can work on with our patients, which is to engage the patient in activities that involve both reaching and manipulation. So in the kitchen, you might have the patient reach up to overhead counter to reach over a plate and bring it back down. The bathroom, you can have them reach up to grab something from the medicine cabinet. Okay, these sort of reach and manipulation activities will really help improve coordination and movement. And by incorporating the upper extremity in functional activities, we can help maintain mobility and prevent a learned non-use. Okay, so those were just a few examples of things we can do with our patients to help them incorporate their upper extremity. There are, of course, so many other treatment strategies. And we'll go over other upper extremity treatment options like constraint-induced movement therapy and other emerging techniques a little later. But before we get there, I want to actually pause here and go over 3 contemporary motor learning principles that we want to keep in mind when we're doing these sort of functional activities that I just mentioned, because it will really help improve motor learning ability. So look at my notes. Okay. The first motor learning principle that I want to talk about is the importance of using random and variable practice. Variable means doing it differently. So that can mean using different tools and objects, or it can mean working in different environments, or it can mean manipulating the location of where the objects are relative to the patient. And random practice is referring to practicing more than just one task within a session, so that you're not doing the same task over and over again in the same session. So instead, random practice would have the patient working on more than one task within a session. So practicing several tasks. Slowly reducing guidance and feedback over time will give them the opportunity to use their remaining resources to get the job done. Because remember, the goal is to get our patients as independent as possible without the therapist. And along the same note of improving their independence, I want to mention one more motor learning principle, which is to help train and teach patients to analyze tasks and problem solve on their own. So as we are tapering off guidance and feedback, we are also encouraging them to figure things out on their own, so that when they're discharged, they can feel confident in their own ability to problem solve. All right? Okay. All right, so let's continue on and discuss other ways that patients can improve upper extremity function, and we'll begin with constraint-induced movement therapy. And the idea behind CIMT is based on a theory of learned non-use, which theorizes that motor recovery after injury is hindered by our learned reliance on the unaffected arms. Makes sense, right? I mean, if you have an arm that doesn't work as well, over time, you'll begin to use your stronger side and neglect the one that isn't working, right? So CIMT works to reverse the effects of learned non-use by essentially forcing you to use the affected limb. And it does that by physically constraining or restraining the unaffected arm, and intensively training the weaker arm by using it to perform daily functional tasks. And this, you guys, is a very intense and structured program. I mean, you're wearing the mitt on the unaffected arm like 90% of waking hours, with 6 to 7 hours of intense therapy a day for about 2 to 3 weeks. So it's not for the faint of heart. And I'm not going to go into all the pros and cons and the inclusion criteria here, but suffice it to say that studies have shown increased motor control and greater improvement in upper extremity function in patients who use CIMT. And it's also shown improved gray matter reorganization and cortical organization. I mean, our brain is so amazing. It has the ability to change and adapt by reorganizing itself and forming new neural connections and pathways through new learning and experiences and challenges. I mean, this is neuroplasticity, you guys. And one of my former professors, actually at USC, Dr. Sean Phibbs, has a TED Talk on neuroplasticity and occupational therapy. So if you're interested, take a listen. I'll have a link in the video description. Okay. Now let's talk about some emerging techniques for treating the upper extremity, beginning with some common orthotic devices. So if you thought the concept of constraint-induced movement therapy was cool, well, say hello to the NEST Hand Rehabilitation System, NEST H200. It used to be called the Handmaster, so it gives you a clue on what it works on. And it's a custom-fit orthosis that uses functional electrical stimulation to re-educate the muscles and reduce spasticity. And it helps patients improve hand function, like grasping, opening, or closing the hand. But as cool as this may be, it's actually quite expensive. So not something that everyone will have access to. And there's SableFlex. That's another orthosis that's designed to help patients with stroke and hand function. And unlike the NEST H200 system, this one is more affordable. It's a dynamic wrist, hand, and finger orthosis that helps patients with wrist extension to open the hand so they can use it for functional tasks. And The training protocol for this is based on the motor learning principle that emphasizes repetitive task-specific training. So with SableFlex, our patients can practice grasp by flexing the hand. And for release, there's a spring system. So the springs will assist with finger extension when they relax the hand, okay? So pretty cool stuff. All right, let's talk about another technology, neuromuscular electrical stimulation. And just right now, when we were talking about the Binez system, I mentioned that the technology uses functional electrical stimulation, right? Well, functional electrical stimulation is a subcategory of neuromuscular electrical stimulation. So it's sort of an overarching umbrella term and includes all the modalities that attempt to produce a muscle contraction using electrical stimulation. And this modality can be especially useful to decrease shoulder subluxation. All right. So with technology today, we can also use robot-assisted therapy to assist in movement, to help with passive range of motion, or when the patient can complete a movement independently. And studies have shown that the use of robotic devices is most beneficial with patients that have more moderate to severe motor impairments. And some of the more common ones you might hear is in-motion robots, since I think it's one of the first robotic devices to be developed, as well as the mirror image motion enabler. And I'm not going to go into too much detail into all the robotics and how they work in this video, but there are some really cool videos on YouTube that you can check out to see a real demonstration of how they work. In fact, there's an occupational therapist that demonstrates the use of InMotion. Makes me so proud. It's really pretty cool stuff. Then there is virtual reality. Oh my gosh, I feel like virtual reality is still in its infancy, and I'm so excited to see where it goes. But this virtual reality and interactive gaming technology like Wii has been shown to improve motor recovery. And again, this is not something that I'm going to talk about too much here because you can go to YouTube for some demonstrations. There are really great, neat therapy games out there, and it amazes me how far we've come to incorporate these into a part of stroke recovery. Okay, what else? Oh, mirror. Okay, so the mirror visual feedback, that's the one that I want to talk about next. So it's commonly known as a mirror therapy. And to do this one, you would place a mirror, like right here, vertically right in front of the patient at the table. They would then place the weaker arm, so the affected arm hidden behind the mirror. Sometimes there's a box where you just put your hand in so you can't see the affected arm at all. And the unaffected, stronger arm will be in front of the mirror. So what they're seeing through the mirror is a reflection of their stronger arm, and they cannot see their weaker affected arm because it's hidden. So while the view of the affected arm is out of sight, you would tell the patient to go through a series of different movements with their hands, like tap the table with your finger and have the patient keep their eyes on the mirror. So while the patient may not even be moving the affected side, because he's getting only the visual feedback from the stronger unaffected hand, this would give the illusion that both hands are moving normally because he's looking at a mirror image of the stronger hand working. Does that make sense? So it's kind of like tricking your brain. And through repeated practice, this trains your brain to rewire itself to improve functioning of the weaker arm. It literally reorganizes brain structures. Cool. That's just really cool. And the last one I want to talk about is mental practice and imagery, which is a method where the person mentally practices a physical skill without actually producing those movements. So you might imagine that a muscle is contracting, even though you're not really activating the muscle. So this could be helpful to do if the patient is injured or unable to perform a task. And studies have shown that people who receive occupational therapy and imagery has significantly more improvement in upper extremity in upper extremity function than those who received only occupational therapy. And if you have any doubt, like I did, on whether or not this can be effective, think about Michael Phelps. If you don't remember, his goggles malfunctioned during the 2008 Beijing Olympics, and he basically swam blind without being able to see anything. But under his coach, he had practiced visualizing this exact scenario and had mentally rehearsed it in his mind. This man. And when he touched the wall on his final lap and he like ripped off his goggles and he looked up, there was world record next to his name. I mean, he went on to win the gold medal. You guys remember like this historic moment? And when asked how it felt to swim blind, you know what he said? Like I imagined it would. Incredible, right? So you too can do this and visualize your success with the MBCOT exam. Write that designation and credentials next to your name and imagine yourself confidently crushing that exam and do it every day. All right. And that brings us to the final portion of this video today. Some precautions that we need to consider. And we'll begin with subluxation. Now, if you suspect that there's subluxation, let's say you use the finger breadth palpation method and you found a 1 finger width gap between the acromion and the head of the humeral head. At this point, we know that there's instability and vulnerability that can get worse over time without proper handling, right? So we have to make sure that everyone, including the patient, families, and other caregivers, are trained in safe handling techniques of the upper extremity. That includes reinforcing proper positioning, proper transfer techniques, and guarding techniques too if the patient is mobile. So what are some concrete examples of things that we can reinforce with our patients and their families? Well, for one, we have to instruct them to be very careful to not pull on that unstable joint. So no overhead pulleys and no aggressive passive range of motion because there's shoulder instability. We also need to make sure that the affected arm is always supported. Do not let it just dangle around unsupported because the weight of the arm and the gravity will place just too much force on that muscle that's already vulnerable. And this can definitely exacerbate the condition and cause pain. So how about a sling then to prevent the dangling? Well, it sounds great in concept, but the use of a sling or anything else that might immobilize or keep the patient in that static, dependent position, like the wheelchair tray table even, all these things are actually controversial. They have to be used with caution. So when considering that route to use a sling or wheelchair tray table, a lot of factors need to be considered, like the patient's cognitive level, their functional level, their pain. Is there pain? Do they have edema? And if slings are worn, we have to minimize that use during the rehab process because it really can contribute to learned non-use. And this sort of like prolonged static position can really put our patients at risk for muscle shortening. And we know by now how important movement is in stroke recovery, right? So the use of slings needs to come under very careful consideration. Now, if the patient is experiencing pain, and you may come across this a lot because the incidence of shoulder pain in patients with hemiplegia has been reported to be as high as 72%. And the range is actually pretty wild, but it has been reported to be as high as 72%. And so what are some things we can do to help reduce pain? Well, we know that movement in the context of functional activity is beneficial for the upper extremity, but we have to now be sure to keep the shoulder flexion within 90 degrees and have them do activities that facilitate external rotation and scapular protraction, okay? Now, aside from shoulder subluxation and pain, we discussed some other upper extremity impairments in my first video that are related to abnormal skeletal muscle activity, right? And if you remember, edema, joint contracture, weakness, and shortening of muscles were some of the secondary complications that result from abnormal skeletal muscle activity. So, what are some of the things we can do to prevent these complications? Well, for one, we have to continuously assess our patients and we need to monitor them and see if there's fluctuation in their tone. And we do that because we want to grade our activities accordingly. Secondly, we want to know what proper positioning looks like, what in supine, in lying, in sitting, and in standing. And we have to keep positioning in mind, not only when they're in resting position, but also when they're involved in transfers or functional activities. And speaking of, positioning, be sure to also know the role of positioning for edema control, because while things like physical agent modalities like TENS unit or compression garments and pressure glove, these all might be helpful for edema control, they might not always be possible, especially if you're in the ICU with all the IVs and access lines. So if edema is present, we would look for alternative ways, such as positioning the limb above the heart. Third, maintain mobility. And I know at this point, we've heard this throughout this whole video, but really important, keep the muscles moving, and moving through functional activity is one of the best ways to prevent contracture. So get them to do activities that include both active and passive range of motion. And a helpful note here when doing these activities is to try to move the patient through a complete range of motion. So we, as therapists, need to find out what each patient's full range of motion is and determine what factors might be limiting the patient from moving through complete range of motion. So is it weakness or is it pain? Is there impingement or do you think it's shortening of muscles? So for example, you might come across a patient who isn't able to move the shoulder beyond 90 degrees during a slow and gentle passive range of motion. But the patient says that there is no pain, so they're not experiencing any pain. Well, let's think this through. It's probably not spasticity because spasticity is velocity dependent, right? And the faster the muscle is moved or stretched, the greater the resistance. So moving on, is it instability or could it be mechanical issues in the joints? Could it be that the head of the humerus is hitting the acromion? No, because that would be painful and they're not going to be able to hide that pain and our patient isn't in pain. So this is where you might begin to deduce that it may be due to the shortening of muscle from non-use and the scapula is just not gliding upward in upper rotation, which is limiting full range of motion in the shoulders. So again, it's important to maintain mobility through active movement to prevent contracture. Okay, final point. We must try our very best to maintain tissue length. For muscles that are already shortened, we can use the low load prolonged stretch. And the concept behind this is that you're applying low load or stretch for a long period of time at the end of the joint's current range of motion. So the patient feels a slight stress, but they can still tolerate it. And splints could also be considered to protect the tissue from shortening or overstretching. So an example might be like a resting hand splint. But similar to the sling, this is somewhat controversial too. And as therapists, we always have to consider different factors and weigh the pros and cons of using a splint. Okay. All right. So I think that's it for today, primarily because I don't think I can stare at that tiny camera hole any longer. I need to go out and look at something in like the far distance to balance my eyes out because I've been staring at this screen too long. And talking about all this movement and activities throughout this video just made me want to go out and stretch and exercise and just move my body. And I hope you do too. Take lots of breaks, take good care of yourself. And as you go through your day and the rest of your week, I hope you'll stop to take the time to notice and appreciate all the movements of your body, both big and small, full range or not, that allow you to engage in your most meaningful occupations. Can't take anything for granted. All right. So that's it for today. See you guys next time. Love you guys.